All right. One topic was how do you use a BNP in your clinical management of CHF? Okay. So a lot of hospitals have either a BNP or a pro BNP. That's more commonly used at the VA. So how do we use those things? Do you want me to start? Or you want to?
Go ahead.
So a BNP is a very tricky tool. Using a BNP, the way that I slice it up is if it's less than 100, you've mostly ruled out heart failure as far as that test is able to do it. It's fairly sensitive that if you do a BNP on a patient with shortness of breath, maybe they're wheezing or something like that, and their BNP is 50, you pretty much have taken heart failure off the board. Now, I would say I would absolutely ultrasound this patient because there are some things that this test doesn't pick up very well. Particularly diastolic dysfunction is not very good at that. So you're going to have to be better than me to pick up diastolic dysfunction, but you give it a try. If it's over 500, you've ruled in that there's at least some heart strain. Okay, that's at least an element of it. Okay, so there is some component of congestive heart failure. Now, they've done a lot of studies about, well, if you're a dialysis patient, you're probably having a BNP of 1,000 at baseline. And unfortunately, it doesn't trend very well. Someone with a BNP of 1,500 is not necessarily 50% sicker than a BNP of 1,000. Okay. However, the tricky spot is when it goes between 100 and 500. So that's kind of the gray zone, and the test basically doesn't help you at all. It's whatever you thought their chances of having congestive heart failure before is essentially unchanged. So I see this get misused a lot where people say, oh, he's not that sick, his BNP is 475, and say, well, actually that test did not really change our likelihood before. Some people have criticized that test in general because it doesn't seem to change management of folks. So especially if you're adding ultrasound to your toolbox, it doesn't seem to really help you tell whether someone's in CHF or not, because the people that are over 500, I'm telling you that a decent physical exam picks those folks up pretty well. It does help you when you get a negative test because you kind of go back to the drawing board and say this really isn't CHF at all. But I will say that I think those criticisms are valid and they're scientifically right, but I can tell you it's a whole lot easier to admit this patient if you've got that bit of number. To tell the cardiologist, like, look, this BNP is 2,000, you can't just ignore this. They need a CHF workup.
And I would say that, I don't know if we don't see the right proportion of CHF in our ED population. I'm not talking about the VA here. I'm talking about MCG. But I don't know if we don't see the same proportion that they see in other hospitals, or we're not diagnosing it enough. But I don't find the BNP to be very useful as an initial test for me making a decision. So history, I would say physical, but it's ultrasound. And then if I don't know the diagnosis at that point, then, great, some lab tests will help. But usually lab tests are really confirmatory. So if I do an ultrasound, I think it's CHF, and the BNP comes back at 20, then I start thinking, well, did I miss something on my ultrasound or my history, and not the other way around? I really like to see those match up to what I already think it is. So I use it as a confirmatory for me more so than a diagnostic tool. Speaking of which, unless you got more on that.
No, that's it.
Let's go ahead.
I just had a real quick question on that. I've been told several times, especially when cardiology rotation did last year, that BNP is fat soluble and can be falsely decreased in obese people. Is there anything written about that? And if so, can it be qualified? Can it be correlated with BMI or anything?
It can. It does decrease in obese, and so you can get false negative findings with that. Unfortunately, those same folks that are morbidly obese are the ones that have so many different possibilities. A lot of them have reactive airway disease problems and CHF, and then some of it's at Pickwickian. There's just so many things, and these folks rarely, in my experience, have had just one thing going on. Part of it is the fact that they've got 60 pounds of extra stuff on their chest that they have to move every time they breathe. It's amazing that more of them aren't short of breath, to be honest. But it is, unfortunately, it decreases the performance of it. You still get it, and it still mostly performs the same. I think it's mostly bickering over minor details. If it's high, it's high. If it's low, it's still mostly low. But I think ultrasound is far better in these folks.
And it is really interesting, too, is that those patients that, like he just described, they come in with shortness of breath, and it ends up being that they've got sleep apnea and they got pulmonary hypertension. And that is a little harder to diagnose unless you're really suspecting it. And so that's why I'm saying I think BNPs throw you off sometimes.